This program was made possible with the generous support of the Magnolia of Millbrae. The Magnolia of Millbrae is a senior living community that provides a variety of services and amenities to its residents. For more information, call 650-697-7000 or visit their website at www.themagnolia.com. MCTV thanks them for their support.
Welcome to Wellness Update. My name is Sherry Plambeck. I'm the Director of Sales and Marketing at the Magnolia of Millbrae. We're a senior retirement community and we offer independent living and assisted living. We're located in Millbrae, California. Today our topic is current breast screening recommendations and early breast cancer detection. Our guests today are Dr. Harriet Borofsky, Medical Director of Breast Imaging at Mills Peninsula Women's Center, and Dr. Andrea Metkus, Director of Breast Cancer Services at Mills Peninsula Health Services. Dr. Borofsky, welcome.
Thank you,
and Dr.
Sherry.
Metkus,
Thank you, Sherry.
welcome.
Thank you.
We are truly delighted to have you here today. And I think early detection of breast cancer is so crucial. And constantly in the media, we're hearing more and more about breast cancer and how it truly touches people's lives, males and females. Can you explain to me, why do we really screen for breast cancer?
Well, I'll start.
Okay.
Since that's what I do every day.
You chime in,
every
Dr.
day.
Metkus,
That's my professional passion. So we screen for breast cancer because as a disease, it fulfills criteria for something for which it's appropriate to screen. And what it means to screen is we are checking, evaluating, testing women who feel fine, who would have no indication of having cancer, in order to try to find very small, early stage breast cancers that therefore can be treated with increased treatment options and therefore to improve survival. So we're screening women who are asymptomatic, who feel fine, in the hopes of detecting subclinical, very early stage tumors.
So out of the amount of screenings that you would do a day, how many of those patients do you have to call back in?
So part of the screening process, there is no perfect test or a perfect screening test for breast cancer. And one of the other reasons to add on that it is appropriate to screen for breast cancer is that, as you said, breast cancer touches all of our lives in one way or another because it is so common. It is the most common non-skin breast cancer. And it's also a disease that's progressive. Right? So early detection is an opportunity to halt the natural progression of the disease, and it does cause death, and that's why we want to screen for this very common disease. But there is no perfect test. Right now the screening test is mammography because it's quite feasible to screen large populations of women. For those of us that have had a mammogram, we know it takes about 10 or 15 minutes. And it's a safe procedure, so it can be done for population-based screening. But it's not perfect. And because the breast, while we're screening for breast cancer, there's all sorts of things that we see on mammograms that can be normal. And we have to sort through the normal, the abnormal, overlapping tissues. So we do call women back to do evaluations, most of whom do not have breast cancer. We call back about 10 to 15% of women. And most of those women that are called back, it's quite a terrifying, high anxiety experience, but most of them turn out to be fine. In fact, if we do find something that we think needs to be further evaluated with a biopsy, 80% of biopsies turn out to be benign. And that's sort of the price to pay for lowering that threshold to detect very early stage tumors, is doing a lot of evaluations to find those early tumors.
Dr. Metkus, do genetics play a role in this at all?
They can play a role, and we certainly, when we're evaluating women who've been diagnosed with breast cancer, one of the main questions we ask, has anybody in your family been diagnosed with it? And there's a strong genetic connection between breast and ovarian cancer in some segments of the population, and we can test for those mutations. They're called BRCA1 and 2, and became very much in the popular press when Angelina Jolie revealed that she was a BRCA carrier. She got it from her mom, who had had breast and ovarian cancer. And so genetics can play a role in the development of breast cancer, but it's actually a very small percentage of women who are diagnosed with breast cancer who carry those genes. It's probably about 5% of women. There are many genes that make up breast cancer that are abnormal, hundreds. So we only really have access to two clear-cut pathways, the BRCA1 and 2, that increase your risk of breast cancer. And if you carry one of those genes that you can get either from your mother or your father, your chances in your lifetime of actually getting breast cancer are somewhere upward of 70%. Those are the highest risk patients. And so sometimes patients who have these genetic mutations will go forward and have aggressive surgery to try and reduce their risk of getting cancer in the future. And so being able to test for that in appropriate women is important, but we have certain criteria we follow to look at who should we test and who should we not test. But after Angelina Jolie came public with her gene carrier state, then a lot more women were asking whether they should get the test.
Now, breast cancer is just not related to women wholly. I believe men can also have breast cancer. Am I correct there?
You're correct. Many men have a small amount of breast tissue under the nipple area, and how it is generally detected is they feel a mass or pain in that area. And probably the ratio for every one man diagnosed with breast cancer, there's somewhere between 100 and 1,000 women diagnosed with breast cancer, but it can happen in men.
Screening guidelines are becoming more confusing. We hear on the media constantly things are changing. What are the current screening recommendations?
I don't think there is a screening test as hotly debated or emotionally debated or as controversial as screening mammography, because there is certainly a public health impact in screening women. And the current recommendations, according to the American Cancer Society, the American College of Obstetrics and Gynecology, and the American College of Surgeons, is baseline mammogram by the age of 40 and every year thereafter, except if you have a first-degree relative. If your mother or sister had breast cancer at a young age, you begin screening 10 years earlier than the age in which they were diagnosed.
So some people might start at age 30 then.
If their mother had breast cancer at the age of 40, that would be an indication. Women younger than 30, we usually do not do mammograms because there is a low-dose radiation exposure from having a mammogram. So if a woman is younger than 30, for example, if they have a known genetic mutation, we'll start screening them, for example, at 25 with MRI. Then when they reach the age of 30, we do mammograms and MRIs, and we sort of screen appropriate for the individual woman, her constellation of risk factors. So for most women, it's a screening mammogram every year. For some women, it's other imaging modalities.
As one ages, and we all seem to be living longer and healthier lives nowadays, say somebody 80, 85, would they still be having a mammogram on a yearly basis?
It sort of depends on the woman. I would say if a woman at the age of 80 or 82 or 85 is in excellent health, has no other very serious diseases, if they would act upon a very early breast cancer diagnosis, it's appropriate for them to be screened. So it's hard. There is no established upper age limit for screening because how we age and our overall health is so variable.
I just want to second what Harriet said, is if a woman who's older, who's 85, who's out playing golf twice a week, she should get a mammogram, because no question she can physically undergo surgery and other treatments. But if someone has significant heart disease and they're on home oxygen and their life expectancy is very short, even at the age of 75, it may not be something that they would want to do. But again, as Harriet said, as long as you are going to receive the information if there's an abnormality, need for a biopsy, potential need for surgery, as long as you're going to go ahead with those processes, then it's reasonable to do the screening test.
It's really a healthy woman screening exam, because our goal is not just to do a mammogram. Our goal is to improve overall survival.
So what is cancer exactly? I know that's a broad term, but perhaps you could just enlighten our audience a little bit on that.
It's an interesting constellation of genetic abnormalities that happen over long periods of time. Again, probably hundreds of mutations in the way a cell signals itself to either grow or stop growing or change. And as these mutations might accumulate, either from genetics that you've adopted from your ancestors or from the environment, there's a lot of reasons that can cause genetic abnormalities or mutations. And so it's not just one disease. Breast cancer is not one disease, and cancer in general is a multitude of different mutations that happen inside a particular cell. Ultimately, the cell either has DNA that tells it to grow without stopping. I mean, that's the ultimate thing that happens. And so one cell gets a message to grow, it'll divide into two. Each of those cells get the same message, and then they divide, and then they continue to divide. But when we finally diagnose a woman with breast cancer because there's been a change on the mammogram, or if she's not getting screening mammography and feels a lump in her breast, probably that cell that went wrong somewhere between 5 to 15 to 20 years earlier. But it takes an accumulation of cell change and then tissue change to be picked up by the mammogram. So, the long and short of it is people ask, how did I get breast cancer? How did I get cancer in general? And we have generally no control over that. It is something that is either programmed into our cells, or the cells accumulate these abnormalities and then become cancerous.
Do you think stress has anything to do with causing those mutations to occur?
People ask that all the time, and I wish I knew the answer. I don't know the answer.
It may, because there are definite this is not scientific evidence, this is just 25 years of clinical experience and thinking about it and being asked that question by patients, by you today. Certainly stress plays a role in how we feel and our hormonal levels. There are adrenal glands that live on top of our kidney that are sort of our flight or fright, and they secrete hormones. They secrete cortisol, which makes our heart beat very fast. When we're nervous, they secrete some estrogen, testosterone. So stress may alter those hormonal levels and perhaps have an impact upon our overall environment, and they may promote cancers from forming. To answer your question, we don't know. Do I think stress plays a role? I personally think it does. I just don't know how to scientifically quantify it.
Less stress is probably the best in anybody's life, don't you?
Yes.
Well, certainly for other diseases where there's a clear-cut tie to hypertension and heart disease due to these adrenal hormones that Harriet was mentioning, those things are not good. That makes us feel like we are being chased by that big tiger from long ago in our histories. But I think the immune system probably plays an interesting role in the development of cancer, or its ability to go on to become a significant clinical problem. Many people think that we're forming little small abnormal cells or even cancerous cells frequently, but the immune system can target those and destroy them essentially. But it's hard to know. Everybody handles stress differently, and we just don't know that answer.
Early detection is such a key. Can you explain the impact on treatments of early detection?
I'll start, and then I'll hand it over to Andrea. And, after you've been in practice for me it's been 20 years. You start to think about what are you doing and why, and I do in order to know how a screening program is actually achieving its goal at early detection, you really have to look at your outcomes analysis. And I do that every year, and certainly we have 20 years of looking at our data, and we certainly have diagnosed early stage breast cancers. In fact, 80 to 85% of the cancers we diagnose are stage 0 or stage 1. How that has impacted generally how we treat patients that see Andrea, there's been a paradigm shift really quite remarkable from when I was, for example, a medical student and in my residency, where the treatment is now focused on most women who are candidates for certainly more minimally invasive surgical options, breast conservation. When I was first in practice, any woman diagnosed with breast cancer, invasive breast cancer, had a axillary lymph node dissection, which can really have consequences down the road. But because of early detection, so few lymph nodes were involved, Now patients can have sentinel lymph node biopsies, which are much less invasive procedures. Radiation therapy that used to be 6 weeks can now be 1 week for some women. Some women who would have had chemotherapy are candidates for not receiving chemotherapy. Have you observed?
Right, so certainly the smaller the cancer at detection, the less invasive the treatment can be. If you imagine, 150 years ago at the first radical mastectomy, women came in with big masses that sometimes eroded through the skin, and the surgical thinking at that time was you had to take the breast, the muscle, all the lymph nodes, and people were obviously badly disfigured by that. We look at that as barbaric now, and we've learned about the tumor biology that didn't save anyone's lives. Breast cancer can impact people's longevity because of the cells that actually leave the breast and go to other parts of the body. So as mammography came into being in the 70s and has gotten to the point where we can detect very tiny cancers and detect them with great frequency, we can do smaller surgery. The radiation can be less invasive and intensive. Yes, we don't have to take out all of a woman's lymph nodes to know that they were all negative. We can take out the first draining 1 or 2 and examine those under the microscope. So as smaller tumors have been detected, the intensity of breast cancer treatment has lessened. We've also learned other genetic lessons from the tumors. We can study genetics in a different way in the actual cancer, and we have a better idea of which women might need chemotherapy or which women don't actually benefit from chemotherapy. Breast cancer in the medical world is one of the most studied diseases we have, so we're constantly making adjustments. We can get a 1% survival benefit here. We can have less pain and suffering from the patient for doing it this way. And so I was just telling a patient the other day that perhaps in 20 or 30 years, the people who are treating breast cancer at that time will look back at what we're doing now as barbaric. I mean, it doesn't seem that way compared to what was done 150 years ago. But thanks to screening mammography and actually excellent chemotherapy and hormonal therapy manipulation, women are living longer with breast cancer, not dying of it. And surgeons, we've contributed a little bit, but it's quite amazing.
Quite a bit. When a person goes in to have the mammogram done, and let's just say they're one of those very few small percentages of the population that's called back again, and they go back again, the procedure then is to have an ultrasound?
It really depends on why the woman is being called back.
It could be to have another mammogram.
It could just be that there's just a question of an area looks a little bit denser, there can be overlapping tissue, there can be some small calcifications, and it depends on why the woman is coming back. Sometimes extra views clarify the situation that everything is normal, or convince us that there's some little tiny calcium particles, we need to take a biopsy of those because some very early precancerous or cancerous changes can cause small calcium particles. Maybe we call someone back in because we're seeing something round and focal, then an ultrasound can be very helpful to determine, is that just a normal cyst? Is it a tumor? Do we need to do a biopsy? So women get called back for various reasons, and then it's a very tailored, focused exam. And they're always given their results. But most of the time, it turns out to be okay.
So you had mentioned stage 0 and stage 1. What is a stage 0 breast cancer?
So most breast cancers, not all, start in the ducts of the breast. And a stage 0 breast cancer is when the cells lining those ducts undergo normal changes throughout our lives. But as we talked about, a cancer cell is a cell that starts dividing out of control. Stage 0 breast cancer are in fact cancer cells, and there are some that are more aggressive than others. They start dividing. They are malignant. They are unregulated growth, and they start packing and distending the ducts. But for some reason, they have not discovered a way or do not have the genetic ability or undergone the DNA changes to invade the duct. It is invasive breast cancers, tumors that invade outside the duct where there are lymphatics and blood vessels, and that's how cancer cells can spread to the lymph nodes and elsewhere. Stage 0 are cancer cells confined to the duct. They have not developed the ability to invade, and they are curable. Those cancer cells just need to be removed. And that's our favorite sort of breast cancer to diagnose because it is early stage, it's curable, and it doesn't require chemotherapy.
However, what we do know is that if we left some women alone who had those cells in their milk ducts, they're never going to invade. We just can't predict for any one woman right now whether you have that type of stage 0, what we call ductal carcinoma in situ, which means contained. So some women with DCIS, or this in situ stage 0 cancer, we could probably not do anything about it, but we don't have a way to differentiate the woman who you have to treat so that it doesn't become invasive, because in some women, if you left it alone, it will invade and then it can become a life-threatening problem.
So it's better to be proactive.
That has been the standard. Now, again, in 20 years that might change, because we might be able to evaluate genetically these cancer cells and say these are not harmful cancer cells, if you can even say that, but these are. And we might be able to really tailor individually for each woman whether they should be aggressive or not aggressive. And so that's going to be the interesting frontier for stage 0 breast cancer. But we as clinicians, when we see a woman with DCIS, we're like, you don't really have cancer. It's not an invasive type. And anyway, but when you hear the word carcinoma attached to your name, you know, it sends just a panic through everybody. So we try and say
it's
okay,
moving quite quickly.
It does.
Dr. Metkus, tell me about surgery for breast cancer. How has that changed over the years?
Well, as I mentioned previously, it used to be a very radical surgery. I still meet women who maybe 40 or 50 years ago had everything removed. They even had skin grafts. You can kind of see their heart beating right through their skin. To where now, when Harriet diagnoses most all of the women at our breast center with an early stage cancer, we take them to the operating room. They get an intravenous line. They get some really happy medicine through that. We use local anesthesia to take out the lump and the lymph nodes, and the surgery takes 45 minutes, and they're back to work the next day with some Tylenol or Advil. So, I mean, sometimes we still have to do mastectomies, and now in this modern era, we have great breast cosmetic reconstruction, which is covered by insurance. So we have a plastic surgery team that we work with if a woman, for some reason, needs a mastectomy. And some women just choose mastectomy, even though we know from 50 years worth of data that there's no longevity. I can't keep you, Sherry, on the planet one day longer by doing a mastectomy rather than a lumpectomy. There's absolutely no survival advantage. So for small tumors, we can do a lumpectomy, have the woman's breast really looking quite good afterward. For large tumors, sometimes we try and shrink them with chemotherapy before surgery. And the worst is the large in situ cancer, where those milk ducts are packed with cancer cells throughout large areas of the breast. We cannot do a lumpectomy for patients like that. So those patients end up with a mastectomy and reconstruction.
Is that mastectomy and the reconstruction, can that be done at the same time? What are the health hazards of that?
Right, so it's a longer surgery. There's more discomfort and pain afterward. There are different types of reconstruction, but we highly recommend, if a woman is interested in breast reconstruction who's thinking about a mastectomy, that it be done at the same time. We call it immediate breast reconstruction. It's not perfect at the end of the first operation, but a woman's breast is removed, the cancer is removed, the lymph nodes are checked, and then the reconstruction is done either with their own tissue, say from their lower abdomen, it's kind of a tummy tuck is done there, and that tissue is brought here with blood vessels and makes a beautiful breast reconstruction, or an expander, and then an implant is placed. So there are multiple steps to the reconstruction, but it's much better to get it started because we spare almost all of the skin the day of the mastectomy, so that when a woman has her final result, it's almost all her own skin, which gives a much better cosmetic result. Sherry, if you have a mastectomy and we have to close the skin that day, we have to take most of the skin away, and you have a long scar across your chest. Then 2 years later, if a plastic surgeon has to do reconstruction,
is that like a pocket?
Yeah, they have to put something in to stretch that all out, and so the bottom line is it's much better to do it all on the same day.
So if a person is having that done and that's done all on the same day, I would assume that they might have to go back again just to have some additional reconstructive surgery done?
Right. Sometimes we can actually, in certain patients, we can actually spare the nipple and areolar skin, and we make an incision below the breast. And when those women wake up, they look down and they see their breast intact, even though the whole inside of the breast is removed. Otherwise, we do have to do it in stages. Sometimes if an expander is placed, then the implant has to be placed, and then a nipple is reconstructed. If it's tummy tissue, then pretty much that's done that day. The nipple can be reconstructed. And then the other thing that's come into being surgically for the plastic surgeon in the last several years is something called fat injections or fat grafting, where you actually do a liposuction procedure, taking out fat, say, from an area that you don't want, and that fat is then grafted or injected into the breast, and it can really sort of make perfect a breast reconstruction. So when I have to offer a mastectomy to a patient, at least I know that I work with a plastic surgery team who's going to really make the woman feel whole after losing her breast, which is just great.
So what other options are there if a patient chooses not to do that? Are there other therapies out there that one can have?
Surgery is still the primary therapy. It really is. The other treatments such as radiation, hormonal therapy, and chemotherapy are called adjuvant or additional. And we know that surgery is not perfect, and after lumpectomy, radiation works, because if there are any little errant cells in the area, the radiation can kill those cells. Chemotherapy, if there are cells in the body, obviously that's how it works. So it would be extremely rare for us not to start with surgery unless the patient was too frail or too ill to have surgery. And in those patients, we do put them on a hormone blocking medicine, which works well. So if you're 95 and you're living in a nursing home and your doctor says there's no way you can go to the operating room, we still do treat the breast cancer, but with medication rather than surgery.
Are there new therapies on the horizon?
Well, the only thing I was going to mention, and it's not clear for breast cancer specifically, but I think over the next 10 to 20 years, we are going to be learning and seeing more and more activity where the immune system is harnessed, boosted, and then fighting people's tumors. So I think if we were going to say broadly what's on the future for cancer, it's going to be immune-based therapy, where your own immune system is essentially boosted, trained, it goes to the gym, and it learns how to attack certain parts of the cancer process. And we've already seen really amazing preliminary results in certain types of cancer. For breast cancer,
the only other thing I can see on the horizon is genetics. I think that's sort of the future of medicine, and understanding that breast cancer is not one disease. It's very heterogeneous, and really evaluating an individual woman's tumor, its genetic profile, and then targeting therapy for that particular genetic profile. We're already doing that now, depending on whether tumors have an estrogen receptor, the progesterone receptor, something called the HER2, with targeted treatments. I think in the future, we're going to be learning more and more about an individual woman's tumor's genetics and then targeting treatment.
And we may target sequential mutations in the cells. So when Herceptin, targeting this HER2 receptor, was discovered by the scientists at Genentech, that was revolutionary. I mean, literally, it took an extremely aggressive breast cancer and made it look like a regular breast cancer when you received this medication. And then right after that came a second target for that same molecule called Perjeta, and that has now been shown to do incredible things. And those are just two of our main targeted therapies. And so perhaps what will happen one day is you'll look at your 10 targets and there'll be, a combination of medications. So I think Harriet's right. We're getting more and more personalized in what the biology of each tumor. And we might say, for you, Sherry, you should have this. And for you, Harriet, you might have this. And you can talk to each other. You both have breast cancer, but it's totally a different disease in each of you. So I'd love for there to be a day after I retire when women don't need surgery for breast cancer at all.
And what if we could prevent it in the first place? Wouldn't that be amazing?
I think it would be wonderful, but I think the early detection is so key, and the sooner at age 40, I guess that's becoming of age, at age 40, is to get that mammogram and really get a baseline and then just keep going back every year. I'm not sure everybody does go back every year. It's kind of like doing your taxes. You should really put that on the calendar as something that you should do, because early detection and all the new treatments that are out there nowadays are really going to make the difference and keep us living healthier and happier lives. I want to thank you so much, Dr. Borofsky, for coming today.
Thank you so much, Sherry.
And I also want to thank you, Dr. Metkus, for taking the time. And I think we are so blessed in San Mateo County to have such a wonderful medical team at Mills Peninsula Health Services. So thank you all for joining us. Live each day. Life is so very, very precious.
This program was made possible with the generous support of the Magnolia of Millbrae. The Magnolia of Millbrae is a senior living community that provides a variety of services and amenities to its residents. For more information, call 650-697-7000 or visit their website at www.themagnolia.com. MCTV thanks them for their support.